Hello? I'm going to go to record. It is. Hello?
Hello.
Oh, okay. I want to make sure I could hear y'all.
Okay.
I think we just have 5 more minutes. I'm going to try to pull up some notes here. Let's see. Let's see. Okay, yeah, let's start here. Is that Maria?
Yes.
Can you see my screen?
Yes.
Does it have like handwritten notes that start with chapter 7?
Yes.
Okay, I want to make sure I had that pulled up. Okay. Thank you.
Okay.
I guess we'll give everybody 5 more minutes. I'm going to try to go try to see. I'm hoping everybody got, well, everybody should have gotten the link. I know it ain't going to do that to me tonight.
What? Did you already take you off?
I wonder if I should go on there.
Maybe, yeah.
Because that's crazy. Oh, no. No internet. I don't want to deal with that all night.
Connect to there.
I tried.
Horrible. What are these?
Were they on the front porch?
Yes, in a grocery bag. Someone dropped them by our house, I guess.
They did not.
No, Julia Cable.
I don't know. That's insane. Hey, Charity. I guess everybody's running a little late.
Hey, how you doing?
Good. How are you?
I'm doing good.
I guess everybody's running late. I'm usually the one that's late. We'll give everybody a few minutes. Hopefully they'll click in. Weird. Oh, there we go. I guess. You made what?
Little tiny hair ties. They smell.
It's because of the fresh fabric. You know, the nose thing is supposed to keep your, like if you wear glasses, it keeps you from getting.
I can't handle all of these. Some are really bad.
It's like old, it's like fabric. Yeah, it's weird. I have no idea.
How did you not remember?
Well, hopefully there would be more than 4 of us. We got a lot to cover. No, this is the only link that y'all got, right?
Yes, ma'am.
Okay, I'm just making sure. I wanted to make sure that we have. because I don't want to start till everybody gets here, because I'm gonna go backwards a little bit, because I think there's some questions about chapter 7 and chapter 8 that I want to make sure y'all have. And I tried to simplify it some. So hopefully we can get through this. But did you leave them in the bags, the individual bags? What's that? That's so weird. That's a wintertime mask. We're talking about masks. Is everybody wearing their masks when they go out in public?
Yes.
Sometimes.
Yeah. I feel like it's getting, I think because of the population is like growing, you know, all these college students coming back and everybody coming, the numbers are on the rise, but the people are on the rise. Like we have more people in town now. So I feel like, you know, places that we were all out last week now are closed because they have it. So I think if you're going out in a crowd, you probably should wear one at this point. I don't like it, but I'll do it if I have to.
Yeah, it's getting worse, it seems.
It is. And I think because, I mean, you figure in a couple months we're going to have flu season.
I know.
And then we're going to have problems again. So I don't.
Kingley said she's going to be a few minutes late.
Okay. That's okay. You know what? I'll use this. And that way you can use your phone, or you can use that. Wait, is this not going to bother you? No.
Chinese response to COVID.
Oh, let's see. We'll wait till most people are here and then we'll. I just want to be sure that you guys have 7 and 8 down packed.
WHO has said it did provide timely information and directed countries to take precautions in January. Going forward, the administration says the U.S. does not have a
She had a ball with that. A ball. And I think I'm going to, with chapter 10, chapter 10 is, can y'all all hear me okay? Okay. Y'all can? Everybody can hear me? I just want to make sure y'all can all hear me okay. Let's make sure. Mario, you can hear me okay? Farah?
Yes.
Jess, Rachel? Maria, I talked to Maria. Mary, you can hear me okay? I think people are just muted.
Yes.
Yeah, okay. I just want to make sure I had it up loud enough y'all could hear me okay. I think for chapter 10 is basically, the way we did it last semester is that we just kind of skimmed over chapter 10, because chapter 10 is basically about emergencies and what to do in those type of situations. It's pretty much like putting it all together, but a lot of it is, you know, codes, different codes, what to do with like ST segment elevation and depression. So I think I'll do what I did last time, and chapter 10 will be a take-home test, except y'all won't be taking it home, you'll be getting it online. So I'll just send it to you, and then or actually I can just go ahead and put it into Blackboard, and I will have a due date by whatever date, and that'll give you time to just do it when you can, because it's not something that you have to have chapter 9 to actually do chapter 10. So it's not going to matter either way. So what I'll do is just wait until next week and then have like chapter 10 due on that Monday. Does that make sense to everybody?
Mhm.
Because chapter 10 you can read on your own and answer chapter 10 questions, and then I'll just put it on Blackboard. I'll let y'all know when I put it in, but we'll go over it briefly. Chapter 9 is definitely more important, and I will give you the key points from 10 that you have to know, that you'll need to know for the certification exam, and then it'll be like an open book type of test. You won't have like an hour to get it done. I mean, there won't be like a time limit. It'll just be like you'll have to be done with it by a certain date. So is that good with everybody?
What is
Mhm.
chapter 9's questions do?
I'm sorry.
What does chapter 9's questions do?
What is on Tuesday, I guess. Well, the first half, because I don't know if they came out in half or just the answers did, or if y'all got all of them at once. But they come straight out the book. But we'll say they're all due. Let's just say all of them are due by next Thursday. Because the front half of them is really the first part of chapter 9, and then the rest are chapter 9 is a big chapter, and it's broken up into, basically I broke it up into 2 sections, like your atrial rhythms and then your like ventricular rhythms or your junctional rhythms. So it's kind of broken up like that. So as long as you do them, the point, and I've always said the point of doing them is to kind of have you reading the material, looking it up, answering the questions. So is everybody good with next Thursday? Just turn them in.
Yes.
Yes. Is
Down
that
here
going
it
to be
says,
for chapter 9?
today, virus again on the rise.
So really what the big thing is that you get them done, because with the way the grading is for the homework is basically if you've done it, if you've turned it in. So, and then
Okay. When is
I'm
our
sorry.
test for chapter 9?
When is the test?
Yes.
Well, we're going to have part of it next Tuesday, but we're not going to do chapter 9 in a whole test. Again, I think it's too much. I think we still need to review 7 and 8 a little bit, which we're going to do tonight. And then we're going to talk about the first half of 9. So then I think it will be easier to understand. It'll be easier to take the test. It'll be it'll be clearer. That's the way we did it before. And I think it helps to sink in a little bit. So we'll do first half of chapter 9 test will be Tuesday. And then the second half of 9, because that's really the final in chapter 10 will be due on like Sunday or Monday. Because then I think they're going to have your lab at the school on that Monday or Tuesday. And then you'll check off on your lab skills and you'll be done. Because once you've passed all of these tests, she was mad about something. Once you pass these, then you can't go to clinicals if you haven't passed. So we got to make sure you pass the class, then they can start you with your clinicals. But then we will keep reviewing. I mean, off the clock, it's not mandatory. Again, I always say, if you're given the opportunity to have a review or get more information, or just even if you have a study group and you meet and talk about it, it does help. And a lot of you know, if you listen to the review from Monday on YouTube, or you were there, that was packed full of all the information you could have needed on the test.
Okay, so is our state certification test before our clinicals or after?
It's after, because you have to do clinicals before you take your test. Because in order to sit for your test, you would have had to pass this class and then do your skills check off in the lab and do your clinicals. Then you can take the test. That's why I say, because of the way it's kind of stretched out, like last semester, we finished the class, they did clinicals like that week and then took the exam. So it was all still really fresh. So this is a little bit different than that. But again, if we get together, if we make up some times and say, okay, we're going to get together and review for your certification exam up until the date you take it, I think you'll be fine. Everybody good with that?
Yeah, I was asking Jessica the other day if she had a specific date for the clinicals, and she said not yet because Emmett hasn't
Right.
contacted.
They are, and I think their targeted date is July 1st for like to open up for back to clinicals. So, I mean, which is really just a few days after this class ends. So,
Yeah.
and then once because you only have to
The
do
clinicals are Emmett?
They'll send you an email and tell you
Yeah.
where your clinicals are.
And
Oh, okay.
Did y'all all finish that clinical stuff that was required from each facility? No?
One
Yes?
facility.
Like they sent you like clinical like study guides and stuff you had to do.
I had like 33 tests for Prisma.
Yes. Right. So y'all, but everybody did what they were given, right?
Yes.
Okay.
Yes.
Because you have to have that done before clinicals too. I don't handle anything that has to do with clinicals. All I do is the material part, the teaching part, and then Jessica and Carolyn handle like the clinical stuff. But I do know you have to pass this class in order to go to clinicals, which I don't see that going to be a problem for anyone so far. But then you do your clinicals. So, but like I said, we'll study and review before you take the exam.
Can you do the rundown one more time? Next Tuesday, we're going to have the first part of Chapter 9 test. Is that what you
Yes.
said?
Mm-hmm.
Okay.
And it may have a little bit of review, what we're going to go over tonight. I just want to be sure. I need everyone to ask questions. If we go over something, I'm going to go over this quick, like, just 7 and 8, because we should be past that. But if you have a question or something on the test that screwed you up, then stop me and ask, because I cannot explain it if you don't ask me. So yes, next Tuesday, the test will be due before class, and then we will do the rest of Chapter 9 and review a little bit for 10. We'll have another review session before Thursday, and we'll have our test on Thursday. No, back it up. We will have class on Tuesday and Thursday, and then your test will be due before Monday. So they'll give you a few more days to study and review.
Okay.
Trying to give y'all as much time as possible rather than trying to cram it all in.
Right.
So, can everybody see my screen? Let's see.
Yes.
Mm-hmm.
Okay.
Did you send out homework for 9? Because I didn't get an email for that.
With the review questions for 9?
Yeah.
Yeah. But, it's not due till next
You
week.
didn't do it on email. You just put it on Blackboard.
I did it. Okay, I'll send it out because it's not due till next Thursday. So,
Okay.
don't worry about that.
I didn't get an email, so I was just.
I thought I did. I was trying to get everything uploaded into Blackboard, and I probably just forgot to put it on there, but I'll send it out email. And what I'll also do is there's a chart for you guys when you do your practice questions in the book. There's a chart that I'll send you that you can that has the answers, so you can check yourself. And also, I'm sorry.
You sent that.
I did. Okay. There's another chart that gives you. It's a really cool kind of chart where you can plot is this sinus rhythm? Is it regular? And it's like a little chart, and you check things off, and it kind of leads you to your answer.
Cool.
But I want to go
Okay.
back just for a minute, and I'm going to go fast. If it were me and we were doing this online, I would have a pen and a piece of paper, and I would make sure if I even just wrote down 2 things about each topic that you would write it down and take notes, because that's the best way to learn it. But I went back and looked at some of the things that were popular that you guys missed, and I'm just going to touch back on them. So from Chapter 7, even though it seems like we're going backwards, I just want to make sure everyone knows this. So like I said, I can send y'all this, but again, you can read it all day long, but until you write it down or talk about it or ask about it, it's not going to make sense. I just actually took my handwritten notes and threw them on here. So everybody can see this Chapter 7, right?
Yes.
Mm-hmm.
So everybody understands that artifact is some type of interference or distortion in your EKG, correct? Yes,
Yes.
no, other. I need to know, make sure y'all know that. And there are different types of artifact. So if you see it on the certification test, what type of artifact is this? You know that we have studied what these 4 types, right? Somatic tremor, wandering baseline, electrical interference, or broken recording. Those are the 4, those are types of artifact. So I can say electrical interference is a type of artifact, but what causes it? The point is they're going to ask you, do you know how to correct this artifact? So if you know what causes it, you know how to correct it, right? Anybody have questions about artifact or the different types?
No.
Okay. If you don't ask, I can't tell you. Also, what you need to know from 7, dextrocardia placement. Is it the only time we switch V1 and V2, right? Everybody on the same page?
Yes.
Okay. When you place your leads, what do we want to avoid? Implants, scars, scar tissue. If somebody has large breasts, what are you going to do? You're going to put it underneath. Infants to 2 years, what do we remember about that? V3 through V6 go on the right side. 2 to 12, V4 goes on the right side. Anybody have questions about that? No. Posterior EKGs, V7 through 9 go on the back horizontally. What is the key in lead placement? Symmetry, right? So if I put it here on the right lower torso, I have to put it here on the left. We know what to do with a pregnant woman, correct? In her last 8th or 9th month, what are we going to do? Tilt to the left side, elevate the head. Anybody have questions about that page at all? So you saw all of those things on the test on Tuesday. Again, everybody would make 100 on that. Awesome. Anybody questions before we move on? This is review from chapter 8, so I will go fast, but I just need to make sure everyone is clear about these. Okay, so let's go. Everybody knows that. Somebody tell me what the cardiac conduction pathway is. You can read it right here.
Still on chapter 7?
Nope, we're gone. We're left chapter 7.
No, like your paper.
Y'all can't see that?
No.
Oh, well, crud. Let me see. Yep.
Yeah. You're drawing?
Yeah, it's on there.
One heartbeat. Yeah, that's it.
Yeah.
Okay. So we started chapter 8 actually because we got to move on. Like this, I'm just reviewing for you guys, okay? What is one cardiac conduction cycle?
1 heartbeat.
Right. That is all that's happening. So when we look at P, QRS, and T, one of the questions a lot of y'all missed on the test was about ventricular like depolarization or repolarization. That has absolutely nothing to do with the P waves. Nothing. When you see ventricular depolarization and repolarization, what on this cardiac conduction do you think?
QRS complex.
QRS and T, depolarization and repolarization. This P wave is all what? What is this?
Depolarization.
What?
Atrium.
So right, the P wave is all atrium. Do not make this more difficult than it is. Like just think to yourself, what is normal? Because if you don't know normal, we can't go on to what's not normal. So I drew this out. Draw it out for yourselves how it makes sense. 1 heartbeat is 1 cycle along the cardiac conduction pathway. So this is 1 heartbeat. The P wave is your first, your Q is your first deflection, right? The R is your first or your second positive. Your S is your negative. Back to your segment, T wave. This is 1 heartbeat. You remember when we studied about blood flow and it went in through the superior and inferior vena cava? It dumps into the atrium, right? That's what's happening. And it has to get moved along through the heart by pumping action. And what causes that? An electrical charge. So just remember, you got to have electrical and mechanical. So in this P wave, what is happening? Atrial depolarization, atrial contraction. Electrical, mechanical. Does everybody understand this? P wave represents what?
Atrial contraction.
Atrial contraction. Can you see the depolarization or the repolarization? No, because it's caught up here in the ventricular contraction, right? So I don't want y'all to remember anything other right now than this P wave means atrial contraction, because this is what's supposed to happen. What's initiating this? The SA node, right? That's all that's happening. When we go here to this QRS, what is happening? What's contracting here?
Ventricles.
That's it. That's right. Ventricles. Bump, 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 bump. That's your heartbeat, right? Atrial, ventricle, atrial, ventricle. So you got your QRS complex, because remember we said a complex was a series of waves? Well, that's all that's happening here because it's so big. There's not just one. You got QRS. And then the T is repolarization. So in this QRS, electrically, what's happening? Depolarization, right? Of the ventricles. What is happening mechanically? Contraction of the ventricles, right? And then when we get over here to this T wave, it shows us electrical activity. That's the ventricles repolarizing. They're relaxing. So just know this is electrical. When you say depolarization, it's because it's electrical change, you know, from positive to or negative positive, and it has an equal mechanical action. It's contracting. So P wave, if I ask you about a P wave, you know automatically that's atrial. If you are asked about a QRS, or I mean, if you're asked about like ventricular depolarization, repolarization, what are the things on this normal EKG complex that represent that? QRS and T. A lot of y'all included the P wave in that question, and I, for the life of me, could not understand why. But does anybody have questions about this right here on this paper?
No,
Throw them out there.
I do not.
Everybody understands what's going on here. I tried to break it
Yes.
down. If you look at here at my little cute drawing, this is our heart. You know, we studied the chambers, the flow of blood. What is happening here? P waves. What is happening here? QRST. So when you look at this on that EKG, the atrium are firing, the ventricles are firing. The ventricles are now relaxing. It starts right back over. That is what's normal. Draw it for yourself. It makes a lot of sense when you do it like that. You know, it starts up here and it basically goes like a lightning bolt. Electricity's got to flow through your heart. That's why we shock you, because we want your heart to get into normal rhythm. Without electricity, your heart will die. So when I slide it up, y'all can see this now, normal.
Yes.
Hold on, can you just go back
Yes,
to the other one for a second?
I would be glad to. Are you drawing it?
Yeah.
I could send y'all this too, but again, it does help to take notes and ask questions. If we were in class, it would be different. So I'm trying to figure out all these different ways to like make this not seem overwhelming, even though it does seem like it. But if you just remember the basic facts here: P wave, atrium, QRS, ventricle, lub.
Okay.
Okay, everybody good with that?
Yes.
So, when we go to do our measurements, and I know, is Kiki, Kiki, are you here? Okay. I know her and I talked about like the measuring, and it does seem like it's complicated. Again, let's talk about normal. On our normal wave up here, right? We're still talking about the normal. These intervals are important in identifying your rhythm. So we know that you have to measure your PR interval, right? We know it's the beginning of the P to the beginning of the Q. Every time. if it asks you for QR interval or PR interval and you can't find it, or it's not regular, or it's all kind of wonky, then you just put not measurable or varies, or I can't, you can't measure, because there's going to be some rhythms where this is normal. I guarantee out of 1 of 11 of us right here, one of us has an abnormal heartbeat right now. I mean, so, but what we're talking about is normal. So everybody knows how to measure the PR interval.
Yes.
Okay. Then we're going to measure our QRS interval. So again, we just measured, right, how long it took from the beginning of the SA node firing to when the ventricles fired. Do y'all see this PR interval? That is how long it took for that conduction to go from the top of the atrium down to the bottom. This is what's happening. So, I mean, you can kind of think, oh, if that is long, ooh, that's a problem, right? Because I need that conduction to happen quick. I need that blood to be pushed through quick, right? So QRS, what do we know about the QRS? It's ventricular. We want our ventricles to be big and strong and narrow and regular, right? Because that is what's supplying blood to our body and our coronary arteries. So we know that we need to measure our QRS interval. It starts at the beginning of the Q and it goes to when the S comes back to the baseline. Now, what if it's really rapid or you can't tell? You may not always see this Q. You may not always see this S, but you will be able to tell where it comes back. Or maybe it doesn't. But again, you will see that. You will know. So again, does everyone know how to measure your QRS?
Yes.
And the QRS we know is less than 1.2 seconds. And everyone knows that the PR is 0.12 to 0.20. Yeah, he wants to show you. Do y'all understand that? QRS. Do you see how less than 0.12 is pretty narrow, right?
Mm-hmm.
A lot more narrow than your PR. You want it to be narrow. Because if it's narrow, it's firing very rapidly like it should. It's firing strong like it should. It's pushing that blood out. You want to see that. Does everybody know how to measure R to R interval? Is there any question that R to R interval is from the top of this R wave to the top of this R wave?
Mm-hmm.
So if there's 20 blocks here and 20 blocks here and 20 blocks here from R to R to R, that is regular. That is what we want to know about the R to R. If there's 20 blocks here and there's 15 blocks here and there's 20 here and there's 8 here, do we call that regular? No.
No.
That is what we're looking for when we look at R to R. When your eye goes to that strip, that is really what you kind of hone in on first. You can get to eyeball it. I mean, there's going to be some times when there's a little bit off, but I mean, you'll be able to tell. So your R to R, what's important of that is the distance between the R to R's. They should be the same number of small boxes, same number of space. It should march out. You should be able to take your calipers and space them out and march it across the paper with not having to move them. Everybody
You know
okay?
what? Yeah, I'm good with that. But in doing the practice ones that we had to do for chapter 9, and even in all of them, I'm automatically wanting to. The first thing I'm wanting to do is just the 6-second thing. How do we determine, like, if you don't mind going over that again?
We're going to get to that. We're going to get to measuring them after we get what's normal. Then we're going to look at measuring. When do you want to be specific with measuring? If I really need to know this heart rate, because the most accurate is going to be your small boxes.
Right.
But when can you only use those?
If they're regular.
If they're what, regular? Right.
Yeah.
So if my rate is, if I look at my R to R and it doesn't march out and it's irregular, what is the only way I can calculate that heart rate?
The 6 second.
Right. So right off the bat,
Okay.
you know.
Yeah. Okay.
If it's irregular, that is the only way. So can you be specific if it's irregular? No, actually, you can't. That's why.
No,
I'm sorry.
I get that. I'm just trying to determine, is there, are we looking for, I mean, you can use the 6 second on any of them, right?
Yes. Yes.
Okay. So say, I'm trying to figure out, what everything is, the heart rate and everything. But is there any, how am I trying to say this? Is there any a time where I can use the 6 second, but the small or the large block is going to be a better answer, or the
Well,
answer
think
that
about it.
they're looking for?
Which gives you more specific?
Well, the small box.
Right, exactly. So if you have a question or you need to get a specific heart rate, and I don't know the case in that, like if you're in the hospital and the doctor says, I want a specific heart rate, then you would measure. But on a test, or if you, like the other day we had a question and there was like 4 possible answers, and if I had to choose between one of the two, how would I know that it was going to be more accurate if I did that 1500? Because I can only do it if it's regular, but it's more accurate.
Mm-hmm.
So again, you have to base what you're asking. Who's asking you that? If you're just eyeballing something and saying I think it's around 100 because there's 10 or there's 10 complexes here. Is my question, is this regular? Yes. It's tachycardic. But if you need specifics, then of course you're always going to go for the smallest unit that you can actually truly say, hey, there's 20 boxes here.
Right.
Because you know how sometimes you'll have a heartbeat that's on the edge of the paper. Mm-hmm. So then you're like, do I count that? Do I not? You need 6 seconds. So that's when you rely on your little ticks at the top. If you don't have those, then you count the boxes. Mm-hmm. If it's regular. Really? Sorry. But we're going to get to that with the but I want to make sure y'all understand the R to R. So anybody have questions about R to R? Okay.
No.
How about ST segment? Anybody have questions about ST segment?
No.
Does everyone know that the ST segment begins where the S returns to the baseline and it ends where the T lifts off the page, right? Or off the line.
So it ends at the end of the T.
The beginning, where it lifts off the baseline and starts. So it's this period between contraction and relaxation. Remember, a segment is the space on the line between a wave.
Yeah.
Between 2 waves or 2 complexes.
Mm-hmm. I'm just trying to go back and remember, is there any point that we would measure to the end of the T?
If you're doing like your QT interval.
Yeah.
I mean, but you're not asked to do that, what we're doing here.
Right. Okay.
Your QT is that, it's that how long it goes from depolarization to repolarization. That's your QT. But we don't need to worry about that right now because your QT is only indicative of certain things or like medications can cause it. But right now, we're talking about this ST segment. And why that's going to be important later is that ST elevation. So if it doesn't go back to this baseline and it goes above it and it goes here, that indicates a problem. Because your heart's not getting a chance to recuperate. It's really kind of just always staying like irritated. So ST segment, what are we looking at? The end of this QRS complex to the beginning of the T. So remember, a segment is just this portion of the baseline. It's just that. This is the segment right here, right?
Yeah.
This is the segment. Segment is that point on the baseline between the waves. It's back when at baseline. So everybody understands where the S or the ST starts, where it ends, and it shouldn't deviate. There's no set number. It shouldn't deviate below or above. It should return, and then it should be straight until you go into your T. So we have
Right.
just those parts. Your PR interval, your QRS interval or your QRS complex, your ST segment, and your T wave. But what are we measuring? We're measuring the PR, QRS. We want our R to R to be even. But if it's not, it's irregular. And our ST. So anybody have questions on those?
No.
This is all just what's normal. What you doing? So, anybody have questions about these? Okay. So let's go down here. When you are looking at your electrical activity in the heart, what is happening? Do we know what's happening? What's firing first?
Atrium.
Right. At the SA node, right?
Oh, I didn't see you up there. I
That's
was
okay.
looking at the one below.
That's okay. So
Yes.
your SA node. So do we all know the pathway? SA node, AV node, bundle of His after you got your little junction, right and left bundle branches,
Right and left bundle branches.
Purkinje fibers.
Purkinje.
So you know those 5 steps along this pathway.
Mm-hmm.
They are all very important because your electrical impulse starts here and it travels down here. Can other spots along the way cause an irritation or a firing? Yes. Yeah, it can cause another impulse, but we'll get to that. But if they become irritated and they generate impulse, then you'll see that. Or if the SA node doesn't fire, you'll see that. You see, all this electrical activity in here is still going on. So what is an EKG? We already know that. It's electrical activity. 1 heartbeat, 1 complete cardiac cycle, right? Here's your isoelectric line. These are all heartbeats reflected. P wave, QRS, T wave. So what happens? Electrical activity prompts mechanical action. Is there any questions about that?
No.
Okay. P wave, QRS, T wave. All these are in this 1 heartbeat are just this flow of electricity through the heart. It starts, it flows through the heart, keeps going. You know what the segment is? Anybody have questions about what a segment is? What any of these parts mean or what they are? Good.
No.
All right. QRS complex. It's just waves together. You see, I'm just reiterating this again. It's just QRS is your ventricular waves all together. What does the P wave represent?
The contraction of the atrium.
Atrium.
Atrium. What does the QRS represent?
Ventricle.
Ventricle.
Ventricle what?
Contraction.
Right. Depolarization or contraction. So if I say, what is the electrical activity in a QRS? You're going to tell me it is what? What's happening electrically?
Ventricle depolarization.
Ventricular depolarization. Because what is depolarization? It's that charge going from negative to positive. What is the mechanical action that's happening in a QRS complex?
Contraction.
Of the
Ventricles.
Okay. That's all. I mean, it seems like it's so like mind-boggling. It's so difficult, but it's, if you think about it, it's really not. It's literally flow of electricity. Electrically, this is what's happening, and mechanically, this is what's happening. One can't happen without the other. PR interval, we know what that is. It's a wave and a segment. That's all it is. It's the beginning of your atrial contraction to the end or to the beginning of the ventricle contraction. When we talk about morphology, shape, direction of your complexes, your waves, and your segments, they're all going to be described in shape and direction. So if you see what is the morphology, a normal morphology of an R wave, you would say it has a positive deflection. It's, you know, narrow. Does everyone understand counting the boxes? What one large box represents, what one small, and that we measure along this isoelectric line?
Yes.
One box is 0.04. 5 of them are 0.20. How many small boxes are there in a minute?
1,500.
And how many large boxes are there in a minute?
300.
That's right. So large box method, small box, you count the boxes between the R waves, you can figure it out. You can figure out that heart rate. Even just looking at it. You don't have to have a special tool or anything. You could just count the boxes. Now, we're still in this normal P, QRS, T. We talked briefly about a U wave, and the only thing you need to know about that U wave is it is not part of the normal complex. If you see that, first of all, what you need to do is let the doctor know, because usually the presence of a U wave is showing that after the heart relaxes and it has repolarization, there's a little hiccup. That U wave usually represents a potassium problem or heart disease, depending on if it's like deflected upward or downward. So again, a U wave, if you're asked a question about a normal rhythm, atrial contraction or ventricular contraction, U wave is not normal. It's not part of that. So U wave is only present if there's a problem and you would need to let someone know that it was there. That's all. Anybody have questions about this page at all?
No.
Okay. Calculate your heart rate. Now, when we go to do the 5 steps, right? This is where it kind of starts. So if you're asked to, give me whatever this rhythm is, tell me what it is. We started with normal sinus, but there's 5 things you have to do. They never change. If you stay true to that, you will not have a problem. You just have to ask. Remember, ask yourself, what is the heart rate? Okay, well, I know that. I know I can calculate that by 3 ways, right? If it's regular, I can do it any of the 3 ways. If it's not regular, I can only do it how?
6-second method.
Right. So if I look at these, and when you get a strip, if it's all over the place, you want to try to pick out the complexes you can actually make out, that are together. You want to get eyeball in on some like ones that at least you can tell the R to R, So you would count the boxes, R to R, R to R. If there's 20 here and there's 17 here and there's 20 here, can I use the 1500 or the small or the 300 or the large method?
No.
No, because it's irregular. It does not march out. So I can only use my 6-second strip. In this, I see 4. So there's 4 beats, and I do not draw, so, but I see 4 beats, right? That's all you can do. That's 40. That's all you can do if it's irregular. So this is not regular. I can only use a 6-second strip. So what are we going to call
Carmen,
it? Yes.
this is Maria. I'm going to tell you something. This is way better than what we've been learning. This way.
Oh, well, that's good. But we're still, the problem is we've got to, I want to make sure you guys have this, that it makes better sense. That's why I'm, trying to make sure y'all get this over anything else.
This makes sense to me now.
Well, good. That's perfect. That's what I want to happen. So I know it seems like we're going backwards to move forwards, but I think it will help moving forwards. Even though I don't draw very well. So thank you for saying that. So that's irregular. So our heart rate, what do we already know about this heart rate? What is this? Is this
Bradycardia.
it's bradycardia, right? Because what's normal heart rate? 60 to 100. So we already know this is slow. But it has all the parts. It's irregular, but it has a P, it has a QRS, it has a P, it has a QRS, so we know that, oh, it's sinus rhythm, but it's sinus bradycardia. That's why, because it's here. How do we know it's a sinus rhythm? It is coming from the SA node. How do we know that? There's a P wave. Atrial contractions happening. So here we go. We're counting along here. There's 10 boxes between each. In my 6-second strip, it marches right out. So what does that mean to me? Is that regular?
Yes.
Yeah. It's fast, so it's not normal sinus rhythm, but is that a regular rhythm? Yes. So if it's 150 beats per minute, what are we going to call that?
Tachycardia.
It's tachycardic. So it's regular. There's 10 small boxes between each. If we wanted to calculate it by small boxes, we certainly could. Why? Because it's regular. We could do it by 300. We could do it any way we wanted to because it's regular. So again, we had regular 3 large boxes between the R waves. You know, you count your boxes. Just know you can only use those 2 if it's regular. Anybody have questions about those?
No.
So so that was our first step. We had to decide the heart rate, right? All right, we know how to do that. Sure.
Will you be sending us this?
I can, sure.
Okay.
Yep, this is just handwritten notes that I wrote out, just trying to go back over the info to make sure I broke it down even more so than the book or any PowerPoint notes, that it just gave you exactly what you needed. So we know what your first step is, right? Determine the rate. No matter what strip you're looking at, just do your 5 things. Okay, we did our rate. Now we need to do if it's regular. Well, we kind of did that up here, but again, my second step is to write down whether I think it's regular or not. How are we going to do that? We're going to measure our R to R, right? That's all we're doing, R to R. Are we looking at our P waves to see if it's regular?
No.
No, we don't care about that at the moment. All we care about is our QRS complexes. Now, will they look different? Yes. Sometimes they will. Sometimes they won't. Sometimes you have a PVC thrown in here and it doesn't look the same. But we want to see those QRS complexes and we want to measure. So again, it doesn't matter here. If you marched it out, there's 15 boxes in between. They look alike. They have a consistent timing, right? So if we go back up here, what is the definition of regular? It's the same pattern and a consistent time. And irregular, they may look alike, they may look different, but they don't repeat with consistent timing. So that's where they don't march out. They may come sooner, they may come later, but they're not going to march out. They're not going to be a certain number of boxes. When we talk about it being regularly irregular, your QRSs may not look alike, but they do appear in a pattern. So you will see like this, I drew as best I could. Like you see you have a QRS here, and then you have a PVC, and you have a QRS, and you have a PVC, and you have a QRS. That's a pattern. That's a regular pattern. But is that a would you call that regular or irregular? It's truly irregular. Because this, if you see these, you know it's not regular automatically. That's what you would say is regularly irregular. I haven't seen too many questions on a test that would ask that, but you just know if these look like this or they're irregular spaces, but you can see a clear pattern, then that's regularly irregular. You were going to see that later on when we look at PVCs, that you might have a bigeminal PVC where you'll have a regular heartbeat, then you'll have 2 PVCs, and you'll have a regular and 2. There's 2 to 1. We'll get to that. But again, we are looking at these QRS complexes. We want to see the ones that are actually doing something. These aren't really good heartbeats. Look how wide that is. Here, it's regular. There's no other choice here. And again, this is irregular. They may look alike or they may look different, but can you march these out? No. We're concerned with the R to R. That's all we're concerned with when we're determining whether it's regular or irregular, right? So again, it doesn't have to be more complicated than it seems or that it is. It's either regular or not, or it's got a pattern looking crazy here, but truly we want to know, is it regular or irregular? So if you get those 2 things figured out, like once you figure out, hey, it's regular, I know I can use whatever method to determine the rate. But if I know it's irregular, well then, hey, I know my rate right here is 1, 2, 3, 4, 5, 6. That's the only way I can determine my rate, by an irregular heart rate. So does everybody get how to do that? It's how we're doing determining if it's regular or not.
Can you go over the regular, irregular thing one more
This
time?
one?
Yeah.
Really, the main thing to remember about regularly irregular is it's a pattern. So if you saw this, like this normal QRS and then a wide one and then a normal and a wide one and a normal and a wide one, is that regular? I mean, is that an irregular heart rate or heart rhythm?
This still has a pattern.
It has a pattern. If it has a pattern, then it's regular. But if it is a pattern that is not a true, like a rhythm that's normal, then it's regularly irregular. It has a true pattern. And
Will
you
it
will
still
see
march
that.
out?
I'm sorry?
Will it still
Yeah,
march out?
it
Like,
actually will, because this complex and this one will march out. The true QRSs will march out.
okay. Oh, okay.
You see what I'm saying? The true ones,
Yeah.
but is that really regular? No, it's irregular. And where you're going to see that is, like I said, when we get to ventricular abnormalities, you'll have like a bigeminal or trigeminal PVC, and this is what you'll see. You'll see a regular QRS and then a PVC, and a regular QRS and a PVC. And all that is a premature ventricular contraction. That ventricle contracted sooner than it should have. It did not keep in line with its little conduction system. But if that happens consistently as a pattern, then hey, we know what we got here. Again, it's going to be very obvious when you see it. You'll be able to say it's regularly irregular, because when I measure those QRSs, they're regular. They march out. Does that make better sense?
Yeah. Okay. Thank you.
And I think when you see the ventricular rhythms, this will come back and you'll be like, that's what we were talking about. Because you're not going to see this a lot. You'll see that bigeminal, trigeminal PVCs. But knowing, honestly, for your test, and that's really the only time you're going to need to really be able to like say irregular, it's just knowing, is this regular or irregular? And if I see a pattern and one of my choices is this, nope, okay, we'll take that. So really, I wouldn't think too much about this. Just know what it is.
Okay.
So here we go. When you're still talking about regular or irregular, I threw this in here because I wanted y'all to know. If you take your calipers and you measure 20 boxes, then you should measure, for it to be regular, you should do 20, it should be 20 boxes again, right? You should be able to march right out. What happened here? It didn't happen. What happened to that beat? It didn't occur like it should have. This is what we call a late beat. Because was it there on time? No, it was late. Can we call this regular? No. How about this one? We took our calipers and we measured 20 boxes, 10 boxes, and then, oops, like it was here, it should have been here. Is that regular? No. This beat should have been 20 boxes right here. But what happened? That beat came too early. It looks alike. Then it'll throw this off how it looks here. But just know if you can't march that out because that beat is here, it just came before it should have. So that's an early beat, late beat. If I measure with paper and I see it doesn't measure out, well, there's my beat. It's not an arrest. It occurred. It just occurred too late. So again, that's all in keeping with number 2, determining if it's regular or irregular. Then we're going to look at our P wave. What is important about this P? Don't get, I think on the test, y'all just literally like overthought this a little bit. Third thing we need to do is look at our P wave. What are we looking for? That P wave is what? Atrial contraction. It's where the SA node is. It's what starts the heartbeat. Let's all remember where the blood flows. It goes in. The SA node is up there. This P wave represents atrial contraction, correct? So do we want to look at these complexes? Do we see a P wave? Yep. Is it positive? Is it deflected upward? Yes. Is it rounded? Is it 1 to 1? Is there one P wave for every QRS? That's a normal heart rate, right? 1 atrial contraction, 1 ventricle. So that's what we want to know. Is it there? Is it 1 to 1? Does it look alike? Does it look like the next one? Does it look like this one? How about this one? There's no P wave, right? The QRS is still looking good, but we have no P wave. So if that's the third thing on your list, you would just put no P wave. Oops, okay. Here, your P wave is inverted. So you would just note it's inverted. So let's think about that for 1 minute. If I know what normal P wave should look like, I know it comes from where? Where is it generated?
Atrium.
Part
SA
of it?
node.
A normal P wave is generated in the SA node. So if I have a P wave that looks like this, is that still occurring in the atrium?
Mm-hmm.
Yes. Why? It's there. We have a P wave. But
it could be positive or negative deflection.
Right. But look here, there's a P wave here. It's pretty far. That interval is pretty far, right? But it's there. It's there. So it's being generated in the atrium. Is atrial contraction occurring? Yes. Do you think it's occurring at the SA node?
Yes.
Why? Does it look normal?
Yes.
Does that?
No.
So if normal SA node looks like this, is this coming from the SA node?
No.
Probably not.
No, right, probably not, because it's still occurring in the atrium, but somewhere along that pathway has decided to fire instead of the SA node. Or maybe the SA node got lazy and decided not to. So does that make sense?
Yes.
So we still have atrial contraction. We just don't have SA node. Well, we don't know that, but we know that for right now. So we're examining our P wave. Our main thing about our P wave is we want to know, is there one P wave for every QRS? Does it look normal? You know, if it's not coming from the SA node, we'll find out later. It might be notched, it might be flat, it might be inverted, it might be really, really pointed. They're still coming from the atrium, but not necessarily the SA node. But that's something we'll get to. But right now, we want to know about this P wave, right? So it is there.
Mm-hmm.
So now, anybody got questions about 3? How to look for your P wave?
Mm-mm.
Do I need to ask myself, is it 1 to 1? Like, does it look okay? Do they all look normal? So if I look at 4 complexes along my strip and all my P waves look different, well, I know right off the bat it's present, but they're going to vary. If you have to describe your P wave and they all look different, then all you can say is that they vary.
So if we notate on it that it's notched or it's pointed or peaked or whatever, that doesn't necessarily mean that it may not be coming from the SA, but just in the atrium.
It's still atrium. Is your P wave present? Yes. What does P wave indicate to you?
Atrium.
Atrial contraction.
Right.
So if you have a P wave, we know atrial contraction is occurring. We know in a normal heart, atrial contraction happens and then ventricular contraction happens. We know that the electrical current comes from the SA, it travels down through the atrium and goes into the ventricles, right? So we're still seeing contraction. It's still coming from the atrium.
Mm-hmm.
It's
But the shape of it would tell us that it's something else.
Exactly. The shape, or whether there's 2 present, or whether there's 6 present, or whether one's up and one's down, or whether the PR interval is not appropriate, or it's longer, it's maybe shorter. But if you have a P wave, there's no doubt in your mind that your contraction is in the atrium. Because if you got a P wave, we know what's happening. Now, when we get to heart blocks and we see that they are blocked and they're beating independently of one another, that's a whole other problem. But for right this minute, we know that a P wave indicates atrial contraction. SA node should be firing and sending that conduction down, but sometimes it doesn't. Sometimes it does, and another place is irritated, so it will beat. But again, look for your P wave. Here,
so does it make a difference if it shows or it doesn't show? I mean,
yes, yep. Because you can say, I see it's showing here.
Mm-hmm.
It's not showing here. Again, we'll talk about that when we get into atrial like tachycardia. Sometimes you won't see it, and that's where you'll have to rely on this. But for right now, in our steps, just look at your P wave and just describe it. Is there one? Is it present? Is it positive? Is it a normal rounded shape? Or now, sometimes your paper might be wiggly, so it may make your P wave look like it's a little jaggedy looking, but you'll be able to tell the difference. You'll be able to.
What about on the bottom part where there's one upwards and the other one is downwards?
Like here?
Mm-hmm.
That's a P wave is inverted. So that tells me that the atrium is still firing, because any deflection, positive or negative, away from that line means that it's firing, but maybe it's firing from a different spot in the atrium. So all you can say about that is the P wave is inverted.
So the P wave is positive and it's smooth. That tells us that it's the SA node that's firing?
Yes.
Yeah, okay. I just wanted to clarify.
And it's right here next to your QRS.
Yeah.
Mm-hmm.
Okay.
So again, this is where you go, okay, so I got my rate. I got whether it's regular. Now I'm going to look at my P wave, because all these things are going to tell you what's going on. So P wave, it's there. Okay, it's 1 to 1. It looks good. The only things you can really say about it is like 1 to 1. It's present. It's rounded. It's it's consistent, or it varies. You're just going to describe it. Describe it to yourself, because you'll know if these all look consistent.
Right.
If they're all, and when we start looking at them, you'll be able to tell a difference. But again, on this, when you're doing your 5 things, P waves, there's 1 to 1. It looks, this is how they look. Because when you go to number 4 to measure your PR interval, you know what your P is, where it starts here. So again, you just measure your PR interval. And what is normal PR interval?
The 1.12 to 0.20.
Right. So we start at the beginning of the P and we go to the beginning of the Q. That tells us when that SA node fires, or somewhere else in the atrium, but when our atrium contract to when the ventricles contract, that's how long that electrical current should take to get through your atrium, to get to the ventricles, to make sure the blood is being pushed through, to make sure everything works as it should. So when you measure it, Again, you've described it. Now you're going to say, oh, my PR here is 7 boxes. So what's that?
28.
28. Is that normal PR interval?
No.
Not
No,
normal.
it's wide, right? It's a wide PR interval.
No.
So it's present. It's 1 to 1. But is your PR interval normal? No.
Mm.
So if it's 0.20, then it's normal. That's why you would know this number, because if it's wide, that's going to tell us something. That's telling us it's taking longer for that conduction to go from the that atrium to contract, the SA node, to the ventricle. If you can imagine that electrical current going through the heart, it should not take long. It should be, bump, bump. But if it's taking a little bit longer, is the blood flowing through there like it should? No, it's taking longer. And then we start to have other problems. So that's why our PR has, for normal, should be less than 0.20. So everybody knows how to calculate your PR.
So anything less than 20 is normal.
Well, it should be like 0.12 to 0.20.
Okay.
0.12 to 0.20 seconds.
Okay.
Because if it was a whole lot less than 0.12, you probably wouldn't be able to measure it. And then we have to determine, is it because the rate is really fast, or, but yeah, if you measure it, say you go to measure and you can't measure it, then you would just put not measurable.
Oh.
So like right here, you see where I drew this out? Like, there's no P. I don't see a P wave here. Do y'all know? So again, there's no PR interval, there's no P wave. So when you go to answer this, you're going to put it's not measurable. Because you're going to have to say, okay, why is it not measurable? Those are the things you're going to ask yourself when you're all done. I mean, you get to the point where you can look at these rhythms and say, oh, I know what that is. But again, if you do these steps, you'll be able to answer your own question. So if your PR interval is not measurable, then okay, we're just going to put not measurable. If you look here, your PR interval here is 3 boxes. Here it's 6. Here it's not even present. Here it's 3 boxes. What are we going to say about the PR interval?
Varies.
Variable. It's right. It varies. So it's not consistent. The answer is it varies. Because you can only, when you're looking at your strip, you can't measure just one, especially if it's irregular. If it's regular, they should all measure the same. But if it's not regular, you want to be sure you're looking at least 3 or 4 beats to just confirm what you already know. So again, your PR, it varies. So that's your 4th step is to measure your PR interval. It can only be a few things. Present, then it's measurable, or it varies, or it's not. Everybody good with PR?
Yes.
5, analyze and measure your QRS. Where does the QRS start?
At the
When it leaves the
end of,
baseline.
Right. So at the beginning of your Q, right, which is your negative deflection. And sometimes you won't see it. Sometimes it'll be caught up in this. But we know that your QRS is your ventricular contraction. And it is represented, it's big. So, it's not just one wave. It's represented by those 3 waves, the Q, the R, and the S. So we measure at the beginning of the Q, which you stay at the baseline. So even if it's down here, you see, here's your P, but look here, you see where it starts to leave the baseline? That's the beginning of your Q. Everything comes back to the baseline. This is where you start all measurement. So when you go here, where it starts to leave, that's the beginning of my Q. So if I'm measuring QRS, if I want to know what the measurement of that QRS complex is, and what did we say the QRS complex was? What did it represent?
Ventricular.
Right.
Depolarization.
Right.
contraction.
So do we want it to be fast and hard and like really strong? Yes. So we don't want to see 0.16 That's wide. So when we measure from here to here, we get the number of boxes that the QRS. QRS should be what for normal?
0.12 less than.
Right. So less than 3 boxes. So if I have to say, oh, well, this is 4 boxes, what am I going to say about my QRS? It's wide. Look how wide this one is. Don't y'all love my good drawing? So my Q, you really didn't see it because it's kind of caught up in this wide QRS. So our Q is going to start right there, and you're going to measure to here when the S returns to the baseline. So if that's 10 boxes, that's 0.40. That's really wide, correct? Do you think this heart, that ventricle is beating like it should?
Mm-mm.
No. It is not getting that blood out of there like it should. So a wide QRS is a problem. Everybody understand how to measure your QRS. So we've determined our rate. We've determined if it's regular, irregular. We've looked at our PR. We've measured our PR interval. We've measured our QRS complex. And now we determine the rhythm. Now, if it comes from the atrium, if it comes from the SA node, we're going to call it a sinus rhythm. If it is between 60 and 100, it's a normal sinus rhythm. If this is 55, if the heart rate is 55, is that normal sinus rhythm?
No.
Is it a sinus rhythm?
Yes.
Yes. We're going to call it sinus bradycardia, but it's still a sinus rhythm. It still has all the parts that it should. It's just a different rate. It's slow. If it's 110, is it still a sinus rhythm? Yes, it's just sinus tachycardia if it's coming from the SA node, if you have a P wave. If your P is, next to your Q, if it all is the same, it's still sinus rhythm. It's still coming from the SA node. It's just too fast or too slow for some reason. So everybody understand normal sinus rhythm, where it comes from, how to get your 5 steps.
Yes.
Awesome. Hold on, let me find my other. Let me see, did I get to page? What page was that? So anybody have questions on those things that we went through just then? That was basically a rundown from 7 and 8. Awesome. And so again, let's go back. Can y'all see that new sheet I put up there?
Mm-hmm.
Starts with cardiac conduction.
Mm-hmm.
So again, we're still going over this cardiac conduction system. 1 heartbeat equals 1 cycle of the cardiac conduction system. 1 atrial depolarization, repolarization, 1 ventricular. Everybody understand this. It's just 1. That is normal. Remember we talked about blood flow via the superior and inferior vena cava?
Mm-hmm.
Comes in at the top and it goes out via the aorta to the body and the coronary arteries. This is what's happening. Your P wave, contract and relax the atria, QRS, contract and relax the ventricles. There is nothing about the ventricles that's happening in this P wave, and there is nothing happening about the atrium in this QRS.
Mm-hmm.
Got to have these 2 things for a normal life-sustaining heart rate, right? An electrical change and a mechanical action. What happens electrically in the heart? We already went over this. Y'all know these. There's specialized tissue that initiate and conducts electrical impulses that trigger a mechanical action. And what are your mechanics of the heart? Your heart muscle, your heart valves, your blood vessels, and blood supply. Your heart cannot function if these two don't work hand in hand. So what do we do if there's like something wrong? You just have to start thinking in terms of electrical, mechanical. You know what's happening in each. So if I lose a lot of blood, is there anything electrically wrong with my heart? No. But mechanically, can my heart pump and do what it should do if it doesn't have enough blood? No, that's a mechanical problem. If I have a heart attack and part of the muscle dies in my heart or is damaged, is that an electrical problem? No, it's a mechanical problem. If my heart rate is really slow, or it's 20, or it's not firing, and there's no impulse to trigger a mechanical action, is that mechanical or electrical?
Electrical.
Right, because if there's no impulse and there's no heartbeat, there's no SA node that's keeping the blood moving, my mechanical action can't happen. There's no cardiac output because the electrical part of my heart is not working. So if I have an abnormal rhythm, if I have atrial fib, or I have, sinus brady, or I have ventricular tachycardia, is that a mechanical problem?
No.
No, it's an electrical problem. So if I have rapid firing of my atrium and it's not allowing that blood to flow and to fill and to empty like it should in a normal rhythm, that is electrical. So, and it's not that like those are going to be specific questions, but it's getting you to think like my heart rate and my rhythm is electrical. That's an electrical problem. That means those impulses are not flowing. That's why you can't shock a flat line, because there's nothing electrical there. It needs to be mechanical. And you got to have these three things for healthy cardiac output: electrical changes and energy, mechanical components, that's your valves, your muscle, vessels, and enough blood supply. If you don't have one of these working properly, you don't have healthy cardiac output. And the main thing is again, it's just P waves, QRS, T, it's all that mechanical and electrical being shown to you on a piece of paper. So again, cardiac conduction system controls the heart pumping action in a pathway. It's an arranged pathway. We know how it looks normally. All of us have it probably all firing just normally. It starts in the SA node and it continues down through the atrium, through the walls of the ventricle, all the way to the bottom. That's all that's happening. Electrical impulses are stimulating those heart chambers to contract and relax in a coordinated, like even patterned way, right? So each part of that system, and we already know the parts, right? SA node, AV junction, bundle of His, bundle branches, Purkinje fibers. They each are responsible for keeping that conduction going. So along the pathway, they each have an intrinsic rate at which they send that signal. Because as we talked about, if they were all the same rate, we would have a problem, because it would not allow that electricity to flow and let the atrium empty and then fill back up in a way that keep the heart beating. We'd have a real problem. So each part along the way is responsible for conducting that electricity, and they each have their own intrinsic rate. It ensures that the blood moves. So again, if you know the normal pathway and you know what their intrinsic rates are and you know what it should look like, you should be able to look at that and know what's going on. So SA node, what's the intrinsic rate?
46. I mean, 60 to
60 to
100.
100.
Right, 60 to 100. So, and we call it the what? The pacemaker?
Mm-hmm.
Right, because that's where it should start. We're talking about a normal heart. So right now we haven't talked about anything abnormal with rhythms, right? We're talking about normal. SA node, it's the pacemaker. It's setting the timing of those contractions. It's determining whether your heart's beating at 60 and I'm sitting here just chilling, or if it's beating at 100 or 120 because you're like jacked up a little bit. That's what's setting it. When that impulse goes down, the next thing it should encounter in a normal rate is the AV node. And the AV node has a response. It's huge. It has a big responsibility because its impulse is to slow that down. We need that delay, right? So the atrium and ventricles don't contract at the same time. So its intrinsic rate is 40 to 60. And we're going to see later on that AV node is important because you want that impulse to slow down here, especially if you're having a problem in your atrium. So we know the path. Then we go down, so we cross over, right? Are we looking just at atrium right here? Right?
Mm-hmm.
Everybody still follow me? We're talking about these two normal stops along this pathway are in the atrium. But it crosses over, right, into the ventricles here. You got your AV junction, bundle of His. It's in the upper ventricles, like in that interseptum. So it's sitting in that thick septum in the ventricles between the right and left ventricles. And it has an intrinsic rate of 40 to 60. So it crosses over from AV node into the ventricles. So by now you would expect what to be happening? The ventricles to start contracting, right? Because they're now getting the electricity. All we're doing is passing that electricity down. So the intrinsic rate here is 40 to 60. What is its responsibility? To pass it where?
To the bundle branches.
To the right and left, because we need, there's two separate parts of these ventricles. We need all of it to get this electrical stimulation. So it sends it down to the left and right bundle branches. It conducts electricity down to the ventricular walls. And from there, it branches into even smaller ones, right? What are those called?
Fibers.
Right, Purkinje fibers. And their intrinsic rate is 20 to 40 because that's the end of the pathway, right? Like your ventricles have been stimulated, they've contracted, now we need everything to relax. So that is what has just happened along this pathway. Atrial contraction, they get rid of the electricity and they're relaxing now. Ventricular contraction, they get rid of it and now they're relaxing. And this is what my little cute drawing is. But again, here is your atrium and here are your ventricles. This is where it starts. The pathway goes from SA to AV to bundle of His to left and right, and then your little Purkinje fibers, right? And this is normal. Atrial contraction is represented by what? P waves. Ventricular contraction is represented by what?
QRS.
Right. Now this is normal, but thinking forward, do you think that it's always going to be that this is going to start here, it's going to go exactly here, exactly where it should? No.
No.
That's where you're going to start to see problems because this electricity comes here and it's flowing to keep this atrium contracting and keep the ventricles contracting. And in a normal heart, that's what it should look like. Any questions about that?
No.
So we talked there in book and in the terms, if you looked at a red chapter, starting in chapter 9, you'd see where it starts off with like an escape beat. So we know this is our pathway, right? SA node, AV node, bundle is. An escape beat generates after the SA node. If the SA node fails to generate, maybe it's tired, took a break. If it doesn't generate here, an escape beat will pick it up. and it will happen here. Is this still atrial?
Mm-hmm.
Yes. So an escape beat. If it happens regularly, we're going to call it a rhythm. Do y'all think this might be where you would see your P waves looking different?
Mm-hmm.
Yes. Or maybe your PR was looking different? Yes. It's not going to look like normal sinus. An escape beat. When you have that early beat, like, you know, when we tried to march it out, but the atrium, you saw that early one, that's not normal. That didn't come from the SA. Where you call it a beat is if it's just one. If it becomes like 2, 3, then you're going to call it an escape rhythm. It did not occur here. I wouldn't make this harder than it has to be. I would just know that if it doesn't fire here, it will be picked up along the way. An escape beat. Or if you had that early beat like we saw, it was an escape beat. It decided it was going to beat on its own. Also, what can happen here, say this is your SA node's not working. Say you have, actually let's say if it was working, say your SA node was working, right? But you had a heart problem, or maybe you didn't have enough oxygen, or you were on certain meds that irritated your heart. Could some of this pathway misfire? I mean, electricity is kind of funky. It'll misfire all the time. So if part of that gets irritated and generates a pulse, even though your SA node is working, that can happen. It's just an irritation. That's why when we talk about it got irritated and fired, yeah, something bothered this pathway and it misfired. If your SA node wasn't working and it picked it up, then it does pick up as a pacemaker. You've got all this electricity in here. It has to flow normally. But again, sometimes you get a misfire. Sometimes this guy has to come in and, you know, pick it up if the SA node isn't working. We just need to know that in the atrium, these are all what? What are you going to see on your EKG? What are all these? What are you going to see?
A P wave.
A P wave. It's still atrial. It may not look exactly normal. It may be not march out. It may not be correct PR interval, but you may not.
And playing their water and their dogs.
You know what I mean?
Mm-hmm.
You may not.
Having a good time with it.
So again, that's all we're talking about. P wave, atrium. It's not always going to be normal, correct?
Correct.
Right. Your problem is when you have several in a row. I put my little note in here. Because if you have an escape beat, okay, well, that happens. But if you start to see a pattern or you have more than one, well, then that's telling me that there's a problem in the atrium. Because that's all we're talking about with this is atrium. Atrial contraction. This is where, this is what this is called. And so if this is generated because it's irritated, we're going to call that an ectopic beat. So this is an escape beat where it picked it up, right, as a pacemaker. But if it's irritated, even if the SA is working and you get an extra beat in there, extra P wave, that's an ectopic beat. It's outside of the normal pathway. Sometimes you'll hear it called an ectopic focus. But again, ectopic means outside of the norm. Like if you have ectopic pregnancy, it's outside of the uterus. This is an ectopic beat that occurs outside of this conduction pathway. It's still atrial. It's just on its own, doing its own thing. An escape beat or an escape rhythm has picked up for the fact that this SA node isn't working. Does everybody understand that, this part? Again, we're only talking about atrial rhythm here. You're still P waves. Your P wave, you might have P waves that look all kind of different. They might be firing from all over the atrium. You got some problems. That's when they'll have to go in and ablate those areas, burn them basically, so they stop firing. Because you want your pathway to continue normal. As you get older, that pathway gets worn out. Everything starts to irritate your heart. You can get misfiring. That's when they have to go in there and either medicate it, zap it. But again, you're still going to see all these represented as P waves. So everybody know that like dysrhythmia or arrhythmia, if you see these words, what they mean, like abnormal, difficult, something is going on. It's too fast, it's too slow, it's generated somewhere other than the SA node because we're no longer talking about normal sinus rhythm. Does that make sense?
Mm-hmm.
So if we say
Yes.
dysrhythmia or arrhythmia, you automatically know something is not right here.
Correct.
So something is being generated somewhere other than the SA node.
Mhm.
Where can things be generated? We know what our pathway is, right? We know where heartbeats, heart rates, heart rhythms should be generated. So areas of the cardiac conduction system that can conduct or generate a rhythm would be your SA node. That's where we want it to be, right? Sinus rhythm. Or your heart rhythm can be generated in the atrium, right? So it's still you're still going to see a P wave, right? But it's not going to be normal sinus. We're talking about areas that can conduct. Atrium, your AV junction, like where the bundle of His is, that AV junction, or your ventricles. That's when you're going to see a junctional rhythm or a ventricular rhythm.
When you say atria and SA node, isn't that the same thing? Because that's where the atria, SA node is at.
SA node sits at the top of the right atrium, but the electricity flows down to the bottom of the atrium into the AV node. So all along that pathway is all atrium, right? It's all your upper chamber. But the SA node is what makes it fire to begin with. The electricity flows down through the atrium. So say your rhythm is being originated in like just upper atrium, but not in the SA node. It's going to be an atrial rhythm, but it's not going to be generated in the SA node. That's why your P wave is going to look funky. It's going to look off. It's still an atrial rhythm. So if you have a sinus rhythm, you know that rhythm generated where?
SA node.
Right. If you have an atrial rhythm, you know that generated where?
Atria.
In the atrium. If you have a junctional rhythm, even though we haven't looked at it yet, right, in the junction. Or if you have a ventricular rhythm, it originated where? Right. We are talking about where your conduction system, where that rhythm originated. We want it to originate here. It's okay if it originates here. It is never okay if it originates here. Because as y'all know, the way it flows, way the electricity flows, do we want our ventricles, those Purkinje fibers that are only got an intrinsic rate of 20 to 40, do we want that to be what's kicking out blood to our body and our coronary arteries?
No.
No way. That's where you see VTAC, ventricular tachycardia. That's when you have to shock that person because you cannot sustain life in ventricular tachycardia. Your ventricles are big and strong, but they were never meant to originate your heart rhythm. You cannot.
So that cause heart attack?
It would cause actually a heart attack is caused by something blocking your coronary arteries. It's part of that muscle. VTAC is when your heart is so out of rhythm that this top part stops beating. Or, when you're in VTAC, you're not perfusing blood anymore. So you might have already had a heart attack. It wouldn't cause a heart attack. It would be the result of a heart attack. It could be the result of cardiac failure. But a heart attack is usually a blockage or part of the heart dying. This ventricular tachycardia or ventricular fib would be a result of having a heart attack. So if you have a heart attack and your ventricles and the blood supply gets blocked, is your heart going to beat regularly? No. Is your electrical pathway going to be messed up? Yes. Will your ventricles keep beating because they're strong? Yeah, that's the only thing you're going to see on the EKG, because the ventricles are going to hang out and do all they can as long as possible. But it doesn't sustain life. And you're not perfusing at that point. Your body, your organs, they're not getting blood flow like they should. And that's why if you don't shock that person back into rhythm, they will die. So again, any of these rhythms that are in the ventricles, this is a problem. Because we want it to flow perfect. We want it to flow like it should. When you have a heart block, that's a problem in the conduction, and it's exactly what you think it is, of electrical impulses between the atrium and ventricle. So if I know that my SA to my AV to my bundle of His to my right and left and the Purkinje fibers should go at a normal rate, they should flow at a normal pace, and that doesn't happen because there's a blockage or there's a heart block, that means that pulse is being stopped somewhere between the atrium and ventricle. And we'll see the heart blocks. People always get like wigged out about, but actually they're very easy once you figure out like what's happening. Your atrium and your ventricles are not beating and they're not coordinating. They're kind of in a normal heart rate, they're communicating, right? I'm giving you the blood, you're giving it back to me, I'm giving it to you. It's like, I have a bucket, you have a bucket, I've got mine full of water, I'm giving you it, you're giving it back. It flows. In a heart block, that is not happening. But again, if we know what normal is, we know what areas generate the rhythm. We know. Okay, I lost y'all. I'm back now. Can y'all hear me?
Yeah.
So all we did here was move on. I just moved on. I drew it out. Again, y'all might want to draw it out however it works for you. But again, here's your pathway. Where does your rhythm originate? Here's your node, AV node, bundle of His, left and right, Purkinje fibers. Your
papers are not on there.
Uh-oh, hang on, let me share again here. Hold